VPT, veterinary chemotherapy. Veterinary chemotherapy. Veterinary chemotherapy syllabus: antimicrobial agent classification, general principle in antibacterial chemotherapy, antibacterial resistance, sulfonamide and their combination with diaminopyrimidine, sulfon, nitrofuran, nalidixic acid and fluoroquinolone, antibiotic, penicillin and cephalosporin, aminoglycosides, tetracycline, chloramphenicol, macrolides, polypeptides, miscellaneous agent, methenamine, bacitracin, rifampicin, nobiocin, virginamycin, lincosamide, and vancomycin. Antifungal agent, topical and systemic agent including antifungal antibiotic, antihelminthic, drug used against cystoid, trematode, nematode, drug resistant, broad spectrum antihelminthic, antiprotozoal agent, drug used in trypanosomosis, filariasis, babesiosis, coccidiosis, amoebiasis, giardiosis, and trichomoniasis. Ectoparasitic, antiviral and anti-cancer agent, antiseptic and disinfectant, growth promoter, common indigestion drug of plant origin with proven pharmacological and therapeutical efficacies in various animal aliments. New drug and drug formulation. Chapter 1, chemotherapy. Chapter 1, chemotherapy. General consideration. Apart from disease arising as a result of malfunction of some body system or the disturbance of a homeostasis control mechanism, they can also be caused by invading microorganisms or by apparent tissue growth. Chemotherapy is a therapy of infectious disease and malignancy by use of chemical called chemotherapeutic agent. It may be defined as the treatment of systemic infection caused by bacteria, virus, fungi, protozoa, helminth, etc. or malignancy with specific chemical that have selective toxicity for the infective organism or malignant cell with no minimal effect on the host cell. The chemotherapeutic agent have minimal or negligible effect on the host cell. Selective toxicity is an important property of chemotherapeutic which selectively target the pathogen. The basis of selective toxicity is variation in structural component and or metabolic process between the host cell and pathogen. Most of antibiotics exhibit a great degree of selectivity, such as inhibition of cell wall formation, penicillin and cephalosporin, mammalian cell lack cell wall, inhibition of bacterial protein synthesis, tetracycline or aminoglycosidase, presence of specific binding site on bacterial ribosome but not on mammalian ribosome. Bacteriostatic effect of sulfonamide is due to PABA antagonism in folic acid synthesis. Mammalian cells do not form folic acid from PABA but utilize the performed folic acid. Drugs in this class differ from all other in that they are designed to inhibit or kill infecting organisms and to have no or minimal effect on the recipient. This type of therapy is generally called chemotherapy, which has come to mean treatment of systemic infections with specific drug that selectively suppress the infecting microorganism without significantly affecting the host. Due to analogy between the malignant cell and the pathogenic microbes, treatment of neoplastic disease with drug is also called chemotherapy. Antimicrobial drugs are the greatest contribution of the present century present century to therapeutics. Their advance changed the outlook of the physician about the power of drug that can cure the disease. They are one of the few curative drugs. Their importance is magnified in the developed countries. Their infectious disease predominant. As a class, they are one of the most frequently used as well as misused drugs. Antibiotics. Antibiotics. Antibiotics constitute a large proportion of chemotherapeutic agent. The word antibiotic is derived from antibiosis, opposite to symbiosis. Antibiotics are chemical substances produced by microorganisms, fungi, actinomyces, cystids, or bacteria, which suppress the growth, multiplication, or may eventually kill other microorganisms at very low concentrations. This definition excludes other natural substances which also inhibit microorganisms but are produced by higher form, example antibodies, or even those produced by microbes but are needed in high concentration, ethanol, lactic acid, H2O2. Initially, the term chemotherapeutic agent was restricted to synthetic compounds, but now since many antibiotics and their analogs have been synthesized, this criterion has become irrelevant. Both synthetic and microbiologically produced drugs need to be included together. However, it would be more meaningful to use the term antimicrobial agent AMA to designate synthetic as well as naturally obtained drug that attenuate microorganisms. This use of drug in treatment of malignancy come under cancer chemotherapy. However, both anti-cancer and antiviral drugs exert good selectivity. They may exert similar effect on normal cell as they do in the target disease cell of the host. History of antimicrobials. History of antimicrobials. The history of chemotherapy may be divided into three phases. The period of empirical use, mold cured by Chinese on boiled cholmogra oil by Hindus in leprosy, chenopodium by attacks for intestinal worm, mercury by Paracelsus 16th century for syphilis, cinchona bark 17th century for fever. Paul Ehrlich phase of dye and organometallic compounds. With the discovery of microbes in the later half of 19th century and that they are the cause of many diseases, Ehrlich proposed the idea that if certain dye could selectively stain microbes, they could also be selectively toxic to these organisms, and tried methylene blue, tryptophan red, etc. He developed the arsenical atoxyl for sleeping sickness, arsphenamide in 1906 and neoarsphenamide in 1909 for syphilis. He coined the term chemotherapy because he used drugs of non-chemical structure that of most other drugs in use at the time was not known, and showed that selective attenuation of infecting parasite was a practical proportion. Hence, he is also known as father of chemotherapy. The modern era of chemotherapy was ushered by Domecq in 1935 by demonstration the therapeutic effect of prontosil, a sulfonamide dye, in pyogenic infection. It was soon realized that the active moiety was para-aminobenzene sulfonamide and the dye part was not essential. Sulfapyridine was the first sulfonamide to be marketed in 1938. The remarkable efficacy of modern antimicrobial drugs still retain the art of making miracles and considered to be magic bullet. The phenomena of antibiosis was demonstrated by Pasteur in 1877. Growth of anthrax bacilli in urine was inhibited by airborne bacteria. Alexander Fleming found that a diffusible substance was elaborated by penicillium mold which could destroy Staphylococcus on the culture plate. He named this substance penicillin but could not purify it. Chan and Flore followed up this observation in 1939, which culminated in the clinical use of penicillin in 1941. Because of the great potential of this discovery in treating war wounds, commercial manufacture of penicillin soon started. In the 1940s, Waxman and his colleagues undertook a systemic search of actinomycetes as source of antibiotic and discovered streptomycin in 1944. This group of soil microbes proved to be a treasure house of antibiotics and soon tetracyclines, chloramphenicol, erythromycin, and many others followed. All three groups of scientists, Domecq, Fleming, Chan, Flore, and Waxman, received Nobel Prize for their discovery. The discovery of penicillin is described as the beginning of golden era of antibiotics. The term antibiotic was coined by Waxman. In the past 40 years, emphasis has shifted from searching new antibiotic producing organisms to developing semi-synthetic derivatives of older antibiotics with more desirable properties of differing spectrum of activity. Few novel synthetic AMA have also been produced. Classification of antimicrobial agent. Classification of antimicrobial agent. AMA. Different method of the classification. Antimicrobial agents are classified based on mechanism of action, type of organism involved, spectrum of activity, type of action, source of the drug, and chemical nature of the drug. They are classified into many groups according to the convention based on chemical nature. Sulfonamide and related drug, sulfadiazine, para-aminosalicylic acid, diaminopyrimidine, trimethoprim, pyrimethamine, quinolones and fluoroquinolones, nalidixic acid, norfloxacin, ciprofloxacin, etc. Beta-lactam antibiotic, penicillin, cephalosporin, monobactam, carbapenem, tetracycline, oxytetracycline, doxycycline, etc. Nitrobenzene derivative, chloramphenicol, aminoglycoside, streptomycin, gentamicin, neomycin, etc. Macrolides antibiotic, erythromycin, roxithromycin, azithromycin. Polypeptide antibiotic, polymyxin B, colistin, bacitracin. Glycopeptides, vancomycin, teicoplanin. Nitrofuran derivatives, nitrofuran, furantoin, furazolidine, nitroimidazole, metronidazole, thiamidazole. Nicotinic acid derivative, arsenide, pyrazinamide, polyene antibiotic, nystatin, amphotericin B. Azole derivative, micronazole, ketoconazole, fluoroconazole. Other rifampin, lincomycin, streptomycin, griseofulvin, etc. Based on the mechanism of action. See individual agent for detailed mechanism. inhibit cell wall synthesis. Example penicillin, cephalosporin, cycloserine, vancomycin, bacitracin. Cause linkage from cell membrane. Example polypeptide and polyenes. Inhibit protein synthesis. Example tetracycline, chloramphenicol, erythromycin, clindamycin. Causes misreading of mRNA code and affect permeability. Aminoglycosides interfere with DNA function. Rifampin, metronidazole interfere with DNA synthesis. Iodouridine, aclovir, zidovidine interfere with intermediate metabolism. Sulfonamide, sulfons, PAS, trimethoprim inhibit DNA guidance. Fluoroquinolones. फिगर important है. Classification of antimicrobial based on mechanism of action. Type of organism agent against which primarily active. Type of organism against which primarily active. Antibacterial, penicillin, aminoglycoside, erythromycin, etc. Antifungal, griseofulvin, amphotericin B, ketoconazole. Antiviral, iodouridine, acyclovir, antiprotozoal, fluoroquinine, pyrimethamine, metronidazole. Antihelminthic, mebendazole, parental DEC, etc. Anti-tuberculosis, isoniazid, rifampin, ethambutol. Based on spectrum of activity. Narrow spectrum activity against either gram-positive or gram-negative organisms. Example penicillin and streptomycin. Broad spectrum, both gram-positive or gram-negative, tetracyclines, chloramphenicol and erythromycin. But now extended spectrum penicillin, newer cephalosporin, fluoroquinolones are now available. Some agents capable of acting on bacteria, rickettsia and protozoa also. Based on type of action. Bacteriostatic. Example sulfonamide, tetracycline, chloramphenicol, erythromycin. Bactericidal. Example penicillin, aminoglycoside, polypeptides, vancomycin and ciprofloxacin. Here also some static drug may become cidal at high concentration, urinary tract, nitrofurantoin and sulfa and vice versa. Based on source, fungi, example penicillin, cephalosporin and griseofulvin. Bacteria, polymyxin B, colistin and bacitracin. Actinomycetes, aminoglycosides, tetracycline, chloramphenicol, macrolides and polyene. Principle of chemotherapy. Successful chemotherapy is based on the following principle. Selective toxicity. First, selective toxicity. The drug should selectively inhibit or kill the disease causing pathogenic organism or cancer cell without affecting the host cell. Second, chemotherapy should be rational and need to be supported by either a clinical or microbiological diagnosis to identify the pathogenic organism. Third, characterization of the pathogens, including its sensitivity to an AMA antimicrobial agent, is essential. For selection of an appropriate drug, based on pathogenic organism, patient factor, and drug factor. If possible, it is better to use narrow spectrum antibiotic, which is more selective and thus cause less interference with normal resistance bacteria. 5. The drugs should be used in proper time, by proper route, at appropriate dose, rate, and for a proper duration. If an antibiotic is used, it is better to administer it as immediate as possible, as a high dose for a shorter period and continue beyond 48 hours after disappearance of symptoms unless signs of toxicity are seen. This ensures that the organism is eliminated and there is less chance of developing antibiotic resistant bacterial strain. Moreover, the antibacterial activity of a given dose of an antibiotic is inversely proportional to the number of bacteria present. Therefore, earlier the treatment, there is more chance that the infecting organism to be caught in their early logarithmic growth phase. 6. Attainment of effective concentration of a chemotherapeutic agent. Attainment of effective concentration of a chemotherapeutic agent for a sufficient period at the site of infection, tissue or body fluid is very important. 7. Specific and appropriate supportive therapy should be undertaken to overcome the infection. Selection of antimicrobial agent. Selection of antimicrobial agent. The choice of selection of antimicrobial agent in treating an infectious disease is based upon the infecting organism, patient, and the drug. First, microorganism related factor. Microorganism related factor. Successful chemotherapy demands a specific diagnosis, but for a veterinarian in field condition, it may not be always possible. In general, the choice of AMA is determined by choice based on clinical diagnosis of an infectious disease. A preliminary clinical diagnosis should first be made to gauge the likely pathogenic organism. In this case, neither the pathogenic organism nor its sensitivity is much variable, and therefore clinical diagnosis itself determines the choice of AMA, HS, BQ, babesiosis in animal, malaria, TB, amoebiasis in man. Choice based on microbiological culture and sensitivity test. In this case, it is neither possible to guess the type of infection, pathogen, nor its sensitivity, osteomyelitis, meningitis, UTI, wound infection, bronchopneumonia, etc. In such case, isolation, identification, and characterization of the causative pathogen, sensitivity testing, and determination of the minimum inhibitory concentration MIC should be assessed to provide a sound basis for selection of the AMA as well as its dosage regimen. MIC. MIC is the lowest concentration of the AMA that prevents the visible growth and multiplication of a bacterium after 18 to 24 hours of incubation in vitro. MFC. MFC is the lowest concentration of an AMA that prevents the visible growth and multiplication of the fungus after 18 to 24 hours of incubation in vitro. The minimum antibiotic concentration MAC is the lowest concentration of the antibiotic at the site of infection that reduces the growth of bacteria. Example, in vitro about 1/10 of MIC. The minimum bactericidal concentration MBC is the lowest concentration of the antibiotic that results in 99.5% decline in bacterial count in vitro. However, Under the field condition, it may not always be possible to ascertain the above consideration, and the situation may be as follows. When bacteriological lab facility is not available. In such a case, based on the experience, a broad spectrum AMA, tetracycline, fluoroquinolone, sulfonamide, or a combination of antibiotic like penicillin plus streptomycin or gentamicin plus cephalosporin plus metronidazole for anaerobic infection should be administered to cover all likely bacterial pathogens. When bacteriological lab facilities are available, but treatment cannot be delayed. Example: acute mastitis in cattle, septicemia, meningitis, etc., where the specimen should be sent first for microbiological examination, and treatment should be started as in if adequate response is not found. Then the AMA is changed later as per bacteriological findings. Bacteriological facility is available and treatment can be delayed for some time. Example: chronic mastitis, chronic UTI, etc. In such situations, it is better to wait for microbiological culture and sensitivity report, and then therapy is started on the basis of microbiological findings. Animal related factor. Age. Age determines pharmacokinetic properties of the drug. Aminoglycosides are excreted slowly in all animals because of poor renal function, and therefore full dose of drug may cause toxicity. Newborn cannot metabolize an excreted chloramphenicol because of deficiency of metabolizing enzyme and cause fetal gray baby syndrome, gray discoloration of body, flaccidity of muscles, and hypothermia. Tetracycline are contraindicated in young animals and children as they accumulate in developing teeth and bone discoloration and weakening. Functional capacity of kidney and liver. Functional capacity of kidney and liver. AMA with low margin of safety must be used very cautiously when renal and hepatic organs of disposal functions are defective. Drugs like cephalothin, cephaloridine, nalidixic acid, tetracycline, aminoglycosides, amphotericin B, etc. should not be administered in renal dysfunction. On the contrary, erythromycin, chloramphenicol, rifampin, etc. should not be administered in liver disease. Host defense status. Integrity of host defense play an important and critical role in the final eradication of the pathogen, particularly when a bacteriostatic drug is used. Bacteriostatic drug will be less effective very young, very old, and debilitated animal because of poor or impaired host defense, phagocytosis, and immunity. Bacteriostatic drug can cure an infection in a patient with normal defense status immunocomponents, but a bactericidal drug must be given in patients with impaired defense. Pregnancy and lactation. It is better to avoid all AMAs during pregnancy, particularly during the first trimester period of organosynthesis, unless it is very much essential, because this may cause abnormality in the fetus. Tetragenicity, tetracycline, fluoroquinolones or aminoglycosides, penicillin, erythromycin, and some cephalosporin can be safely given in animal. Nalidixic acid and sulfonamide are excreted through milk and may cause hemolysis in glucose 6-phosphate dehydrogenase deficiency. Chloramphenicol, ivermectin, and Many other antibiotics and antihelminthics cannot be given to male animals producing milk for human consumption because of possible human health hazard due to presence of residue in milk. Drug allergy and idiosyncrasy. Drug allergy and idiosyncrasy. If there is any history of allergy of an animal to an AMA, then it should not be given in the dead animal. Antibiotics, especially penicillin, produce several life-threatening anaphylactic reactions in man and sometimes in animal. Aminoglycosides, erythromycin, and sulfonamide, trimethoprim are often associated with allergic reaction and should not be used in allergic patients. Individuals genetically deficient in glucosic phosphate dehydrogenase enzyme, when treated with primaquine, fluoroquinolones, sulfonamides may suffer hemolysis, presence of pus, blood, CSF, and tissue breakdown products. This interfere with the efficacy of many AMAs like sulfonamides, nitrofurans, and aminoglycosides, whereas these factors do not affect the efficacy of penicillin. Location of infection. It determines the choice of AMA and route of administration. Presence of infection behind barrier, example meningitis, abscesses, etc. Effect of AMA on intestinal flora. Ruminants are highly dependent on the integrity of the ruminal microflora, and thus oral administration of broad spectrum AMAs affect the normal flora and leaving the field free for growth and multiplication of pathogenic yeast and fungi, which result in acute diarrhea. Drug-related factor. Third, drug-related factor. A. Sensitivity of the organism to AMA. An AMA to which organism should highest sensitivity is selected. Type of antimicrobial activity. A. Bactericidal AMA is preferred over bacteriostatic in a patient with impaired host defense in serious life-threatening infections and when the infections are behind the barrier. Antimicrobial spectrum. Antimicrobial spectrum. If characterization of pathogen is possible, then use a narrow spectrum AMA which selectively inhibit pathogenic organisms only. When no guess can be made about nature of organisms, then broad spectrum AMA should be used to cover all likely pathogens. Superinfections should be borne in mind. Combination of AMA. Combination of AMAs. Inhibition of bacterial growth with combination of antibiotic is antibiotic synergism or potentiation, where their concentration is less than or equal to 25% of the MIC of each antibiotic acting alone. Inhibition of bacterial growth with combination of antibiotic is antibiotic additive effect, where their concentration is equal to 50% to the MIC of each antibiotic acting alone. This fraction of MIC, FIC of an antibiotic required to inhibit the growth of bacteria in combination when more than 50% of MIC of each antibiotic is required to inhibit the growth of bacteria. It is called ineffective antibiotic combination. Pharmacokinetic properties. Pharmacokinetic properties. Penicillin G destroyed by gastric acid, aminoglycosides not absorbed orally, and chloramphenicol in ruminants degraded by ruminal flora cannot be given orally and are given parenterally. Aminoglycosides cannot pass through the blood-brain barrier and are ineffective in bacterial meningitis, whereas sulfadiazine, chloramphenicol, ciprofloxacin, and rifampicin can pass through BBB and attain high concentration in CSF and are the preferred drug in meningitis. Penicillin cannot readily pass across the pleural or peritoneal membrane, whereas chlortetracycline does the same readily. Ampicillin and erythromycin attain high biliary concentration and can be given in biliary tract infection. Dose of AMA. Dose of AMA. The dose of antimicrobial should be adequate enough of the drug to attain plasma concentration above MIC. At the start of therapy, animal need to be administered an initial loading dose or priming dose to produce effective MAC, followed by repeating dose intermittently at specific intervals and for required duration called pulse dosing. The pulse dose may be lesser or equal to that initial dose depending on the AMA. The primary dose establishes the therapeutic antimicrobial concentration and the pulse doses continue to maintain that level. Hence, can also be called maintenance dosage sulfonamide. However, several antimicrobial or other drugs are administered at fixed predetermined intervals at the same dose level, similar initial and maintenance dosage. The bactericidal activity of most antimicrobial is based on two factors: concentration in plasma or concentration dependent killing. Higher the antibacterial concentration attained, better is the killing. Example, as the concentration of the antimicrobial agent increase in the plasma above the MIC, the rate and extent of bactericidal activity also increase. Example, aminoglycoside, quinolones. Thus, aminoglycoside may be given a single daily dosage instead of thrice daily dosing. Time of which drug is in plasma or time dependent killing. For some drugs, the longer the presence of the drug in the plasma, greater is the bactericidal effect. For such drugs, the presence of the drug in the concentration above MIC for a longer period is needed, and thus the drug level needed to be maintained as long as the bactericidal activity is required. Example, beta-lactam antibiotic, vancomycin. Some antibiotic aminoglycosides, fluoroquinolones, and imipenem exhibit antibacterial effect called post-antibiotic effect (PAE), while some antibiotics continue to suppress the bacterial multiplication even after their plasma concentration falls below MIC. The PAE indicates the time taken for bacteria to return to normal growth. Route of administration. Route of administration. The effective plasma concentration of AMA and their subsequent maintenance depends upon the route of administration of the drug. The IV route is preferred in life-threatening serious infection. Oral antimicrobial therapy is generally preferred in monogastric animal and young ruminant, but oral use of AMA in ruminant is not advisable because of erratic absorption in large rumen and destruction by ruminal microflora, except for enteric infection. Toxicity. If a number of AMA is having similar efficacy can be used for the treatment of an infection, the last toxic AMA is prepared. Penicillin, cephalosporin, and erythromycin are prepared over aminoglycosides tetracycline, chloramphenicol, and vancomycin. An AMA should have wide chemotherapeutic index ratio of median lethal dose to the median effective dose of a chemotherapeutic agent. Wider the ratio suffer the AMA. It is similar to therapeutic index of other drugs. The risk of development of drug resistance among microbes and residues in the milk product, meat, egg must be considered. Cost of AMA. A less costly AMA is generally preferred to expensive one without compromising the efficacy. Complication of antimicrobial therapy. Complication of antimicrobial therapy. Complication of antimicrobial therapy. Toxicity. Many drugs like tetracycline, erythromycin, and chloramphenicol are irritant and may cause pain and abscess formation on IM injection or thrombophlebitis of injected vein on IV injection. Different AMAs show toxicities as follows: aminoglycoside, ototoxic and nephrotoxic; tetracycline, hepatotoxic and nephrotoxic; chloramphenicol, bone marrow depression, aplastic anemia, gray baby syndrome. However, cephalosporin, penicillin, and erythromycin are least toxic and they have high margin of safety. Allergic and idiosyncratic reaction. Allergic and idiosyncratic reactions. All AMA are foreign to the body and are capable of producing hypersensitivity reaction, and this may be in the form of mild skin rashes or a severe anaphylaxis. Most common offenders: sulfonamide, penicillin, aminoglycosides, and cephalosporin. Individuals with genetic deficiency of glucosic phosphate dehydrogenase enzyme when treated with primaquine, fluoroquinolones, or sulfonamides may suffer hemolysis. These reactions are independent of dose of the drug and cannot be predicted. Superinfection. Superinfection. It is the development of a new infection in the patient due to the use of AMA for chemotherapy. It is more common when broad-spectrum antibiotics such as tetracycline, chloramphenicol, etc. or combination of AMA are used. Superinfection is more seen in intestine, causing fungal or bacterial enteritis, respiratory tract, and urogenital tract. Superinfection with protease and pseudomonas. It can be avoided by using narrow-spectrum antibiotics whenever possible and by preventing indiscriminate use of antibiotics. Microbial drug resistance. It is the insensitiveness of a microorganism to an AMA. Staphylococcal resistant to penicillin G and enterococci to streptomycin. Vitamin deficiency. Vitamin B and K are synthesized in the GI tract of man and animal. Use of AMA interfere with the normal intestinal microflora, particularly in herbivores, and therefore vitamin synthesis. They may result in vitamin deficiency in man and animal. Antimicrobial resistance. Antimicrobial resistance. It is unresponsiveness of a microorganism to an AMA, and it is similar to the phenomena of tolerance seen in higher organisms when bacteria are no longer susceptible to the action of antibiotics. The bacteria are said to have developed resistance to that antibiotic. Type of resistance: natural and acquired. Natural resistance. The organism has never responded to the AMA, may be due to the absence of the particular enzyme or target site affected by the drug. This is generally group specific. Example, gram-negative organisms are not affected by penicillin G. The E. coli bacteria are naturally resistant to benzyl penicillin, unable to penetrate cell wall. M. tuberculosis intensive to tetracycline. This type of resistance does not produce any clinical problems as alternative drugs are available. Acquired resistance. Acquired resistance when previously sensitive bacteria become insensitive or resistant to an antibiotic, then process is known as acquired resistance. This is due to replacement of sensitive bacterial population by resistant population. The acquired resistance is through genetical or biochemical mechanism. Indiscriminate use of antibiotics, improper selection of antibiotics, underdose for treatment for longer or shorter period than required, promote acquired resistance. This poses a clinical problem in veterinary practice. Some bacteria acquire rapid resistance, example, Staphylococcus coliform and tubercle bacilli. Bacteria acquire resistance by a change in their DNA. Such DNA change may occur by mutation, gene transfer, infectious resistance. Mutation. It is a stable and heritable genetic change that occurs spontaneously and randomly among microorganisms. It is not induced by the AMA. Any sensitive population with few mutant cells required higher concentration of AMA for inhibition, and these are selectively preserved and get a chance to proliferate when the sensitive cells are eliminated. Lack of competition. After some time, sensitive group is dominated or replaced by the resistant mutant. Example, it happens when anti-tubercular drug is used alone. Mutation may be single step. A single gene mutation may confer high degree of resistance. It emerges rapidly. Example, Enterococci to streptomycin, Staphylococcus by rifampicin. Multi-step, where several gene modifications are involved, develop gradually. Example, resistance to erythromycin and tetracycline. Gene transfer. Gene transfer. Many bacteria contain extra chromosomal genetic material called plasmid in the cytoplasm. This carry gene coding for resistance called R factor. These R factors are transferred to other bacteria and spread resistance. Gene transfer. Infectious resistance from one organism to another can occur by conjugation, transduction, transformation. Conjugation. Sexual contact through the formation of a bridge or sex plies common among gram-negative bacilli of the same or another species. It may involve chromosomal or extra-chromosomal plasma DNA. The gene carrying the resistance transfer factor RTF is also present. Conjugation frequently occurs in the colon, where a large variety of gram-negative bacilli come in close contact. Even non-pathogenic organisms may transfer R factor to pathogenic organisms, which may become widespread by contamination of food or water. Chloramphenicol resistance to typhoid bacilli. Contaminant acquisition of MDR, multi-drug resistance, has occurred by conjugation. Thus, this is very important mechanism of resistance acquisition. Transduction. Transduction. It is the transfer of gene carrying resistance through the agency of a bacteriophage. Example, virus that infects bacteria. The R factor is taken up by the phage and delivered to another bacterium which it infects. Certain instances of penicillin, erythromycin, and chloramphenicol resistance have been found to be phage mediated. Transformation. Transformation. A resistant bacterium may release the resistance carried DNA into the medium and this may be invaded by another sensitive organism becoming unresponsive to the drug. The mechanism is probably not clinically significant. Resistance, once acquired by any of the above mechanisms, becomes prevalent due to the selection pressure of a widely used AMA, i.e., presence of the AMA provides opportunity for the resistant subpopulation to thrive in preference to sensitive population. The resistance acquired by the bacteria may be exhibited in the following way. Production of enzyme that inactivate the drug. Example, beta-lactamase by staphylococci, aminoglycoside inactivating enzyme by E. coli. Decreased accumulation of the drug in the bacterium. Example, resistant to tetracycline by gram-positive and gram-negative bacteria. Altered target for the drug. Binding site may be altered. Binding site for aminoglycosides on the ribosome may be altered. Altered metabolic pathway. Bacteria may produce folic acid by an alternative pathway. Cross resistance. Cross resistance is the resistance seen among chemically related drugs. When a microorganism develops resistance to one drug, it is also resistant to the other drug of the same group, even when not exposed to them. Example, resistance to one tetracycline means resistance to all other tetracyclines. Measure to curb drug resistance. Measure to curb drug resistance. Measure to curb drug resistance. For clinical efficacy of an antibacterial, it is essential to prevent drug resistance. Following measures can be taken to curb the problem of resistance. Antibiotics should be only used when the clinical indications are clear. Do not use AMA if the disease is not infectious, untreatable, or self-limiting. Information regarding endemic infections and sensitivity patterns should be considered before selective of an AMA. Avoid overuse of newer AMA when an already available drug is equally effective. If AMA is needed, treatment should start from narrow spectrum AMA first. Prefer rapidly acting and bactericidal drug, particularly when host defense is impaired. In combination of AMAs against resistant organisms, the individual agent should be used in full dose. Broad spectrum antibiotics should be used only when a narrow spectrum drug is not effective against the organism or unsuitable for the animal. Indiscriminate use of AMA should be stopped. AMA should not be used at subtherapeutic dose or unnecessarily for an extended period. Combination of AMAs. Combination of AMA. Use of combination of antimicrobials may have synergistic, antagonistic, or indifferent no-change effect. Hence, appropriate drugs should be used for combination, but sometimes they are used in combination with specific objective as below. to achieve additive or synergistic effects. The rule regarding combination are bacteriostatics plus bacteriostatics, additive or sometimes synergistic, bactericidal plus bactericidal, additive, bactericidal plus bacteriostatic, generally antagonistic. Synergistic combinations are used in full dose of individual drug for achieving the goal to broaden the spectrum of antibacterial activity. To broaden the spectrum of antibacterial activity, it is necessary in the treatment of mixed infectious and in severe undiagnosed bacterial infections. Combination should not be the substitute for accurate diagnosis to curb the development of resistance. This is very important for the treatment of disease where the organism is notorious for developing drug resistance and for chronic infections requiring prolonged antimicrobial therapy. To decrease the intensity of toxic effect, drug having low therapeutic index when used in their full dosage precipitate toxicity. If such a drug is combined with another synergistic drug in reduced dosage, its toxicity can be reduced. When amphotericin B plus flucytosine combination is used for cryptococcal meningitis, a shorter course of treatment is needed than when amphotericin B is used alone. Disadvantage of combination of AMAs. Disadvantage of combination of AMAs: increased chance of development of variety toxicity. Improper combination results in increase in intensity of toxicity of a drug by another. Promotion of development of resistance or increase in nephrotoxicity. Gentamicin plus cephaloridine. Chances of superinfection are increased. Generate a causal rather than rational view in diagnostic of infectious disease or selection of AMA. Increase in cost of therapy. Chemoprophylaxis. Chemoprophylaxis, it is the use of an AMA to prevent the setting of an infection in the body or to combat a contracted infection before its final clinical manifestation, to reduce the number of the viable microbes below the critical value, thus preventing infection. The chemoprophylaxis may be done against specific organisms, generally high satisfactorily. Example, tuberculosis in man with isoniazid. The prevention of infections in some high risk situations, example, urinary tract catheterization, may be satisfactory, but it is highly unsatisfactory and condemnable, even hazardous, if it is done for prevention of infection in general. Misusage of AMA. Misusage of AMA. Treatment of untreatable disease, example, use of antibiotic in viral disease. Improper dosage. Antibiotics should be administered in proper therapeutic dose. The suboptimal dose will not suppress the bacteria but may precipitate the development of resistant population. Administration of higher dose may cause toxicity to host. Superinfection. Use of oral antimicrobial therapy, especially broad-spectrum antibiotics, suppress the normal ruminal or intestinal microflora, leading to the development of enteric infections by the invading pathogenic microbes. Inhibition of starter bacteria. Use of antibiotic in dairy animals results in excretion of significant level of the antibiotic through milk, which may suppress the starter bacteria. Antibiotic as growth promoters. Use of antibiotic growth promoters in feed lot animal before slaughter without observing withdrawal specification may pose public health hazard. Application of antibiotic in surgical wound without proper drainage. Use of antibiotic to prevent bacterial infection without removal of necrotic tissue debris or providing proper drainage of the purulent exudate result in markedly lowered antibacterial potency of the antibiotics. Antibiotic in pregnancy. Antibiotic in pregnancy. Antibiotics in pregnancy. As far as possible, antibiotics are to be avoided in pregnancy. Very few of them have been known to be safe in pregnancy, like penicillin and some cephalosporin. Many of them, including tetracycline, chloramphenicol, sulfonamide, and aminoglycosides, should be avoided in pregnancy. Probiotics. Probiotics. Probiotics are products containing viable, non-pathogenic microorganisms administered orally to alter the intestine microflora. Lactobacillus, Bifidobacterium, Streptococcus salivarius, some Enterococci, and Saccharomyces boulardii are some of the presently tried probiotics. Studies have shown them to be useful in acute infectious diarrhea following antibiotic administration. Prebiotics. Prebiotics. These are non-digestible substances which stimulate the growth of intestinal flora and thereby prevent the colonization by pathogenic bacteria. Example: lactulose, inulin. Thank you.